Well, thank you very much for that kind invitation. I want to begin by expressing my gratitude for the opportunity to join you as the director of a busy sports cardiology program. Protection of the athlete, keeping people safe, introducing screening and emergency action planning is very much near and dear to what I do on a daily basis, and I'm really delighted to have the opportunity to engage. I'm hopeful that my remarks will set the stage for a very productive day, and the agenda certainly looks quite full and quite exciting. I need to switch over here to my slides. In addition to being here to talk about athlete care, I'm using this as an opportunity to look for a place to live in case the American political climate doesn't change as well. We have some problems at the moment. All right, great. So to begin with some disclosures, I want to very transparently acknowledge that I work with a lot of teams and organizations and do have financial relationships, some of which center around screening and emergency action planning. And there are a number of institutions that fund the work we do in our lab, so I want everyone to be aware of that. Let's start with another anecdote. This is Ryan Shea. Ryan was a close friend of mine, not a patient, but actually an old training partner of mine. Ryan was one of the fittest, most capable athletes I've ever known. He was a sub-220 marathoner, and he is pictured here on the starting line of the Olympic marathon trials in Central Park in November 2007. Ryan made it to the 5th mile mark and collapsed on the side of the road. Resuscitation efforts were slow, but were instituted, but unfortunately Ryan did not survive. And this was a wake-up call in the running community around America about the fact that even very healthy, fit people can succumb to sudden cardiac death. When something like this happens, we as cardiovascular specialists are always posed 3 fundamental questions. And here are the questions. First is, what is the scope of the problem? Meaning, when something like this happens, how worried should we get? How common is this? And how should we balance this with other problems that are facing people and patients? The second is, what are the causes of these problems? What causes people to drop dead suddenly? And this is the issue of pathogenesis. And then finally, is there a viable path to prevention? And that viable path to prevention invariably involves some combination of screening and, more importantly, probably a well-developed and rehearsed emergency action plan. So let's begin by taking a look at some incidence data. I want to run through a series of studies, primarily to make the point that when people ask how common is this problem, the only data-driven response was, well, it depends on who you're talking about. So let's begin with probably the safest group of people, and these are just all-comers, young individuals who attend primary and secondary school. These are data from Kings County, Washington State, in which the incidence of sudden cardiac arrest was tabulated among youngsters at school and also the staff, the teachers and physical education providers that work with these students. And what you can see here is that the incidence of sudden death among school-aged children is roughly 0.2 per 100,000. One of the interesting things, though, is that in school systems, it's not the kids that get into trouble, it's the staff and teachers. And you can see here that at an incidence of 4.5 per 100,000, you're much more likely to be resuscitating a teacher than you are a student. What about athletes? This is probably the most widely cited study looking at the incidence of sudden cardiac arrest, at least in the United States. These are data from Barry Marin's group in Minneapolis. And what Barry did is created a registry over a 26-year period of time in which cardiac arrests were tabulated largely among high school age kids in our country. And what you can see here is over the time of data captured, there was a slow and steady rise in the number of cases. Now, this is not to indicate that this problem was becoming more common. This is simply a function of the registry getting traction and people reporting things more commonly. But what you can see by the last 10 years of the registry is that the incidence rates are relatively stable. Roughly 50 to 60 young individuals in high schools in the US die per year. And when they do die, it's almost invariably a function of some underlying cardiac condition. The incidence statistic that came out of this paper was roughly 1 in 200,000 high school age students will succumb to sudden cardiac death. Now, we all know that registry data are fraught with problems, and indeed an updated look at high school students in the US tells a different story. These are data put together by the folks up at University of Washington, Kim Harmon and John Dresner, who leveraged some state reporting systems to come up with a probably more accurate statistic around what happens in high schools. And you can see here that the incidence statistic they now come up with is roughly 1 in 70,000. So threefold more common than what we initially thought. Let's digress for a second and talk a little bit about the lifetime trajectory of the athlete and what this means from the perspective of community engagement. So if you look at what happens, at least in most developed countries, you'll see that many young children play sports and are active. By the time they get to high school, there's some sort of attrition process where only the better athletes remain engaged. And in the university setting, it's really only the cream of the crop that stay active. And then at the professional level, there are really very few individuals when we think about this from a community perspective. But what's interesting is that the exercise dose, i.e. the stimulus for physiologic adaptation, the stimulus for something to go wrong in the context of disease, moves in the opposite direction. So as the athlete goes from the childhood experience through to high school, to university, to professional level, the amount of exercise, both the intensity and the volume of exercise, goes up quite precipitously. So we've actually thought about this at length from the perspective of studying cardiac adaptations. And I'm fond of telling my fellows that this nexus here, this time of escalation of dose, is a precious period of plasticity where we can really study what happens to the heart and blood vessels in the context of sport. But when we're talking about sport safety, it's important to remember that sports medicine provision tends to lag behind the increase in exercise dose. And what this means, particularly at the university level, is you oftentimes have under-resourced medical staff, but very, very high intense, high volume training. And so this is not only a period of plasticity, this is a tenuous time of tragedy. And we really think that college represents the sweet spot around engagement, both from the screening and the emergency action planning perspective. So what does this look like? Well, in the American collegiate system, we know that sudden death is actually not that rare. Again, these are data put together by the NCAA, led by the Washington group. And you can see here, I've highlighted the highest risk group are male basketball players that participate at the Division I level with a mortality statistic of 1 in roughly 3,000. So we're not talking about a rare event, particularly in this group of people. In college, in our country, this is what the mortality statistics look like. It's 1 in roughly 43,000. So again, as we move from school children to high school athletes to college athletes, the incidence of sudden cardiac arrest just continues to climb. What about older athletes that move beyond the college environment? These are data from the RACER registry, which I have the opportunity to lead. This was a 10-year effort to study sudden cardiac arrest during marathon and half marathon in our country. And what we learned are a couple of important lessons. One is that when it comes to endurance events, distance and gender define risk. So men are much more likely to get into trouble, and the longer the race, the more likely we are to see sudden cardiac arrest. The other thing that we learned from RACER, which I think is a really important take home, is that cardiac arrest does not equal fatality. If you talk about cardiac arrest in the context of most public venues, shopping malls, casinos, airports, you're lucky to see an out-of-hospital survival of 5%. When it comes to the experience around races, we saw a 30% save rate, and I think there have been some more recent reports that suggest that the rate of resuscitation and survival to hospital discharge is actually higher. So something about the athlete collapsing, the appropriate response, indicates that we have an opportunity to really save people in this environment. The other interesting thing about RACER that we learned is that incidence fluctuates with time. And what do I mean by that? I mean that male marathon runners, so the men who are out there pushing themselves through 42 kilometers, actually seem to be dying at increased rates over the time of the period we studied. And the thought behind this is that the demographics of people that are doing marathon racing actually changed during the time we were studying. No longer was the marathon the purview of very fit elite level athletes, but many men, particularly in their 40s and 50s, were simply deciding it was time to fill their bucket lists and were going out and running marathons without proper consultation with doctors. So a sobering lesson there. Triathlon, you're all familiar with, swim, bike, run. Here, it actually appears that the death rate is higher than marathon running, and this is almost all attributable to what happens in the swim. Swimming is a potentially risky thing for triathletes for several reasons. One is they can have simple cardiac arrest. Two, they can drown, and more importantly, we're now learning about the issue, which we call swimming-induced pulmonary edema, where athletes' lungs tend to fill with water from a non-cardiogenic source, and we can certainly talk more about that if they're interested. But the triathlon death statistics look to be similar to what we see in college athletes at one in roughly 50,000. And then finally, at least in our country, the single highest risk group are our active military participants. So these are data from the NIH looking at what happens from a death perspective among our Army, Navy, Air Force, and Marines. And what you can see here, the black bars indicate cardiac arrest in men, the gray bars indicate cardiac arrest rate in women, and the white bars indicate the number of cardiac arrests that are attributable to underlying coronary disease. So you can see here that rates among men and women when they are young are actually pretty low, 3 or 4 per 100,000. But when you hit about the 35-year age bracket, the rate goes up quite precipitously. And the cause of that is, as most of you are well aware, is simple underlying coronary artery disease. So if you were to put this together and compare, again, when people ask the question, how common is sudden cardiac death? The answer is it depends on who you're talking about, with rates being very, very low and children simply participating in school and creeping up as we go through high school, college, and then into some of the more older athletes and our military recruits. Why does this happen? Well, causality data is tricky. This is one example, and the only consistent thing about autopsy studies is that they're inconsistent. When we talk about what the slices of the pie look like, whether we're talking about heart muscle disease, channelopathies, valvular heart disease, aortopathies, the distribution around this pie chart looks different from study to study. One of the most interesting things that I think some of the more contemporary autopsy studies have taught us is that a significant fraction of young people die without any detectable cardiovascular problem, which is very important when we're talking about the yield of screening. Even if we find all of the diseases we know how to identify, we'll never do this perfectly because sudden unexplained death, autopsy normal death is out there and it's alive and well. Now, will that change with genetic molecular pathology? Possibly, but at this point, we still have cases we can't explain. These are the big players, as most of you are well aware. Just go off. There we go. Disorders of the heart muscle, hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, anomalous coronary arteries with high-risk features, most importantly an intra-arterial course, ion channel disorders, shown here as an example of long QT syndrome, and then certainly both valvular and aortopathic heart disease. So these are the issues when we're screening that we're thinking about. And as you look across these diseases and ask yourself, what screening modality is best, pause and remember that there's not one best answer to that. So how do we prevent this problem? Well, you may often find yourself as this guy standing at the crossroads. I know I've occupied this place many times and still do on a day-to-day basis. And the question we have to ask ourselves is when we're thinking about prevention, which is the best road? Should we simply say this is not a common enough problem to do anything about and leave it alone? Should we do a history and physical, or should we add something additional like an ECG or some form of advanced imaging? And as I'll return to at the end of the talk, the road that one chooses to travel is very much a function of a set of defined variables, including specifics of the institution you're working with, personal preferences, review of the data, and what the overall best fit for the organization is. So there are two documents that should probably be credited with starting what I often refer to as the revolutionary screening controversy. And these are the 2005 update of the Bethesda conference proceeding, which was an American College of Cardiology document, and the 2005 European Society of Cardiology International Olympic Committee document. Both of these documents appeared within short order of one another, and both of them had in common a mandate to screen athletes. And the idea was that these groups said, you know what, this problem is worthy of our attention. And as cardiovascular specialists, we should be doing something about it. As most of you know, there's an important difference between these two documents, which I'll touch on in a moment. But the consistency here is that on both sides of the Atlantic Ocean, groups that were thinking about athlete health, athlete safety said, it is our obligation to do something rather than nothing. So in the US, for some time, the standard of care has been the so-called 14-point minimum. And this is the history and physical as delineated by the American Heart Association, in which there are questions about personal history, family history, and then a very, very short list of physical examination maneuvers designed to detect the key conditions. Is this a good system? I would say it is a system that has a lot of room for improvement. We now have some data to substantiate that the history and physical in isolation is not a particularly good tool. These are again data from the University of Washington's group, which have been quite prolific in this area. And this is a paper that just came out a couple months ago in which the history and physical, the performance of the history and physical was looked at. And you can see here at a sensitivity of 18.8% and a positive predictive value of 0.3%, that the history and physical really, although it's not useless, in isolation leaves a lot to be deserved. So fast forward to 2015, in the States, we revised the Bethesda conference proceedings, and we did so with an important new twist. European document still stays the same, but what I will remind you of is the major difference between what is advocated for in the States and what is advocated for in Europe is the role of the 12-lead ECG. In the United States, we have stayed away from a recommendation to mandate ECGs. In Europe, ECG mandates are actually part of how they practice. As an aside, I just returned from a year of work in Lausanne, Switzerland, working with the International Olympic Committee. Had an opportunity to travel to most of the countries in Europe to meet with them to understand what they're doing. And although the ESC document mandates ECG screening, there's tremendous variability, with the bookends being Italy, in which every young athlete is screened at a starting age of 12, to some of the Northern European countries in the Scandinavian region, which don't do any screening at all. So although their document says everyone should be screened, I just want to remind you that at the local level, many of the European countries are making their own decisions about how to implement this. So where does the European recommendation come from? Well, I think most of you are familiar with this, with these data. These are data capturing the Italian experience. Italy had a clustering of deaths in the late 1970s among their competitive athletes, and in doing so decided to implement an ECG inclusive screening program. This became mandatory law in Italy in 1981. And what you can see here is that the incidence of sudden death in their population of screened athletes over the period of their study time dropped relatively quickly. And by the end of their study, it looked as if the incidence of sudden death in screened athletes was actually lower than the incidence of sudden death in unscreened non-athletes. So in essence, their call to action was, if we use ECG, we can take a high risk group and we can reclassify them as a very low risk group. It was a really tantalizing story. I remember when this paper came out, it probably raised more questions than it answered. And one of the important questions that it raised is, how do we study this fact? And I think the Italians really helped, or I'm sorry, the Israelis really helped us understand that the way we study this, the way we count our cases, dictates the answer that we come up with. So very much similar to what happened in Italy, Israel had a cluster of sudden cardiac deaths in their military and decided to implement a mandatory ECG screening for all of their military recruits. And they took a look at what happened to the incidence of sudden death during their screening time. And when they published this paper, they went on to make a very important point, and that is that if they had counted the cluster of sudden deaths as part of their study period, then it looked like ECG screening was very effective. If they started counting after the sudden deaths occurred, it looked like ECG screening really didn't move the needle at all. So on one end, we have the Italians championing ECG screening as a life-saving tool. On the other end, we have the Italians saying, or the Israelis saying, maybe it does something, but you just need to approach this with a little more equipoise. So where's the truth? What do we need? Well, what we need is a multinational prospective blinded comparison of sudden death screening practices in which we compare nothing to the history and physical, to the history of physical plus the ECG, in a diverse gender ethnic group of people with different ages, competition levels, athletes that are adequately powered to determine the impact on sudden death, cost efficacy, and downstream implications. I can't even say that, it's such a big mouthful. But the truth is don't hold your breath. We're never gonna see this. The reason is twofold. One is that this is still a relatively rare event. And in saying that, the implication is that the cost of putting together a study like this is prohibitive. So we will, as far as I can tell in my lifetime, never see the definitive randomized control trial addressing what screening does. So we have to then step back and say, what are appropriate surrogate outcomes to look for to do this correctly? And this is something we've been thinking about for a while. And this was the nidus for a study we did now more than 10 years ago, in which we asked the question, if we address the primary outcome variable, not as sudden cardiac death incidence, but as disease detection, how good is the history and physical, and does the ECG add anything? And so the study that we did, which I believe was the first prospective study comparing history and physical and ECG, was done at our university. We took 500 or so consecutive recruited athletes. We subjected them to the AHA 14-point system, which is the standard of care at that time. And then as part of the research study, we performed an echocardiogram as a way to define disease, which is not perfect, but it was the gold standard we used in this study. And then we did blinded ECGs. So what did we find? Well, we found that the vast majority of these student athletes were perfectly healthy. 75% of them had totally normal looking hearts by echo. About a quarter of them had evidence of physiologic remodeling, so big hearts that looked healthy. And a very small group, so 11 out of 508, had something on echo that caught our attention, either markedly dilated or thickened hearts and or some sort of valvular abnormality. And so we put all of those 11 people through non-investigational screening to determine whether or not they actually had disease. And at the end of the day, 3 out of 500 people had a condition with some relevance to sports safety. But the question of this study was, how good a job did the two different techniques do at picking up these problems? So what you can see here on your left-hand side of the screen are the abnormalities that we identified, bicuspid aortic valve, some mitral valve prolapse. We identified one case of PS and then some big hearts. At the end of the day, as I said, only 3 of these people had conditions we care about. One moderate PS case with gradients that were deserved of balloon valvuloplasty, one HCM patient, and one runner with a post-viral myocarditis and an EF of 35%. Question was, how good a job did the techniques do at identifying these people? Well, it turned out that the history and physical does a good job looking for and detecting valvular heart disease. The stethoscope is still alive and well, and so there is a role for examining young athletes. None of these conditions were sport restriction conditions, but valvular problems can be. But it was really the ECG that detected the cases of heart muscle disease that we cared about. And so we concluded from this study that adding the ECG to the history and physical improves the sensitivity. However, this strategy is associated with really high and perhaps prohibitive rates of false positive testing. Our experience was very much reproduced by 2 other United States institutions, one Kansas and one University of Virginia, in which they introduced ECG screening and found false positive rates in the 10 to 20% range. So if you're thinking about bringing a screening tool to a group of healthy young people looking for rare conditions, and you have false positive rates of 10 to 20%, this spells really big trouble. So the big trouble is not from a function of the ECG screening not being the right tool. It was really a function of how at that point we were using the ECG. And what this led to was a series of attempts to define and revise ECG criteria that are specific for the athlete, with the last of these being published in 2017, the so-called international criteria. And at this point, the papers that we have looking at the false positive rate, sensitivity, specificity with these new criteria suggest that we're operating on a 1 to 2% false positive rate, so much better than we were 10 years ago. I want to conclude by talking about 2 papers and 2 papers that I think have moved the needle in the right way. Neither paper is perfect, but I think both papers will provide us with a foundation for the discussion that we're going to have as the day moves on. The first is the revision of the Bethesda conference proceedings, and the second is a document that I really had a lot of fun working on, and that was the NCAA sponsored document around student athlete safety. So first of all, in the States, and I think this is consistent both with what you're doing in Canada as well as what's happening in Europe, history and physical continues to be a recommended part of athlete screening. Importantly, history and physical with the liberty to choose your tool continues to represent the universal recommendation. So in our country, if we were ever called to task from a medical legal perspective, the onus is on us to document that we've asked the right questions and performed the right physical examination steps. The second is that there's been a push to really standardize the way this is done. And probably the tool that most people are familiar with is the 4th PPE monograph. This is a tool that was designed by the American Academy of Pediatrics, which really helps us think about how to ask the questions effectively and how to do the physical exam steps appropriately. And so there's a push to really reduce heterogeneity in the process and to minimize sloppy practices. The third thing, and this is where the needle really shifted in this paper, is that for the first time an American document didn't say don't do ECGs, it said consider ECGs with several caveats. And what this document, and I fought very hard for this, what this document ended up saying is that screening with ECGs may be considered, assuming there's close physician involvement, that there's an understanding of the accuracy issues around the test, and that there's the cost infrastructure required to support the downstream findings. So for the first time, we have an open door invitation to really generate some local decisions with some important caveats. The NCAA document, as I said, was really a joy to work on. I want to really credit Brian Hainline, who's the chief medical officer for the NCAA, with allowing the group of us that sat down to write this to really think outside the box about screening. And there are 4 major things that came out of this document, again, that I hope will serve as fruit for our discussion today. The first is rethinking the rationale for the PPE more broadly, and that is moving beyond just the simple concept of identifying sudden death and thinking about the other things we can do when we engage athletes. Second is the issue of quality control. Third is the consideration of the role of ECG. And fourth, and most importantly, is the emphasis on emergency action planning. Basically, how you do things is as important as what you choose to do. So rationale for the PPE, we're all thinking about the history, physical, and the ECG for identifying things that kill people. But this is also an opportunity when we bring our athletes together to ensure that non-fatal, non-high-risk health conditions are being managed appropriately, that we're identifying barriers to performance, that we're establishing relationships with these athletes, which will allow them to come back to us if problems arise, that we're assessing characteristics that may put them at risk for future injury or disease, that we're reviewing medications and providing therapeutic use exemptions if necessary, and then we're educating students about high-risk behavior on campus. This really suggests a much broader view of the PPE with goals that extend beyond detection of occult high-risk pathology. The second is quality. And again, I've mentioned this already, but the concept of what you do is probably less important than how you do it. And so one of the things that we wrestled with is the recognition of the fact that the AHA 14-point recommendation is probably not sufficient. And in this document, really encourage people to extend their questioning, extend their physical examination to that which is suggested by the fourth PPE monograph. The real key quality areas are standardization of the history and physical, written documentation that should be kept in a place that's accessible by athletic training staff and medical staff, a collaborative team approach in which athletic trainers and doctors work together, the opportunity to do as much on campus as possible, and then really respecting the role of the team physician. And I can't emphasize how important this is for us as cardiovascular docs to remember that at the end of the day, the sports medicine team physician needs to be comfortable with our recommendations and comfortable with how to implement return to play when that's appropriate. What does the NCAA say about the ECG? It says that it's okay and probably represents best standard of care if proper planning is in place, if there's an explanation to the student athlete about why we're doing this, if standard and contemporary interpretation standards are used, and if there's skilled cardiology oversight. So another way of saying this is don't embark on an ECG screening program without a planning process, a communication plan, familiarity with how to interpret the ECG, and skilled sports cardiology collaboration. So back to this poor chap who's standing at the crossroads, I'm going to use myself as an example and make the point that there really is no one right way to do this. So what there is, I believe, is a right way to approach the problem. And I do this in a stepwise approach. The first is to really have the important local dialogue. So when you're charged by a team, a university, an organization with the question, how should we screen our athletes? The first thing is to identify and engage the relative stakeholders, to know your literature and adopt a philosophy, to assess resources. And I'm not just talking about money, I'm talking about staff time, I'm talking about physical infrastructure. And then importantly, to identify any league recommendations or mandates that your peers are doing. Second thing to do is extend the dialogue externally and to rely on your peers. So that's what we're doing here today. This is a dialogue that involves people, experts, thought leaders from all across your country getting together to ask the question, what should we do and how should we do it? Third is to reach a consensus. When teams or organizations do something and there's a lack of consensus, that's when the strategy tends to break down. So if there are dissenters within the group, it's very important to bring people together and figure out the common ground. Establish your metrics and track them. So I feel very strongly that if you're going to put a screening program into place, tracking it over time to understand what your impact is really the only way to do so, because without that, you're not able to revise and share your work with other people. So by way of example, again, this guy standing at the crossroads, I have the opportunity to oversee medical care for the Boston Marathon, and we ask ourselves every year, should we be screening athletes? And we've made a decision that that's above the scope of what we can do well, so we really do nothing. We rely on the athletes to get their care locally and responsibly come with their own screening done before they arrive for the marathon. Curry College is a small university in the Boston area that has an amazing sports medicine staff that's inclusive of one person. They have one athletic trainer. So when they came to us and asked, what should we do? When we talked to their administration, their bandwidth was really only such that they could do a high quality history and physical, and that's what they stick with, and they do a very good job of it. As I mentioned at Harvard, we've spent a lot of time studying the ECG and how it impacts screening, and we've put together a program that we're proud of, and it works for us. And so there we have turned a research opportunity into a standard of care, and we involve the ECG. Sometimes it's out of your control. When I take care of US soccer athletes, we're mandated by FIFA to do ECG and echo before every international competition. That is not, in my opinion, the best way to do this, but if we want our athletes to travel to World Cups, that's what we're mandated to do. So again, no one size fits all. With that, I will conclude, and I appreciate your attention.
Andrew's next, but let me just, Aaron, thank you very much. Very heavy, it's a pair of running shoes. Canadian running shoes.
Thank you very much.
Thank you, that was great.
Appreciate it.
We'll have a lot